Hello everyone, welcome back to this series of lectures in nephrology. Today we'll be discussing about the vascular diseases of the kidney. So, when we speak about the vascular disease of the kidney, we are looking at both the large vessels, which includes the renal artery, and we look at the small vessels, right? The small vessels which basically include your segmental arteries and your capillaries, right? So, the disorders which affect these large vessels or small vessels are your vascular disorders of the kidney. So, the main diseases which affect the large vessels is basically your renal artery stenosis, and small vessels is your thrombotic microangiopathy. So, when each or either of these disorders are present for a long time, they both can result in CKD, and the CKD that occurs as a result of this chronic long-standing blood supply mismatch is what we call as your ischemic CKD, ischemic chronic kidney disease. So, when we speak about the vascular disorders of the kidney, we have the large vessel as well as the small vessels. The large vessels such as the renal arteries, for example, renal artery stenosis. The small vessels include your segmental arteries, arterioles. So, the classic disease that we learn is your thrombotic microangiopathy. So, let us look at renal artery stenosis. So, renal artery stenosis we have learned in our chapter on hypertension, right? So, renal artery stenosis is one of the most common causes for secondary hypertension. It is amongst the causes for your renal causes of hypertension. So, this is why it is also called as renovascular hypertension. Okay. Renal artery stenosis we also looked at in our chapter on hypokalemia. Okay. So, the most common cause for renal artery stenosis is atherosclerosis, right? So, we have the kidney here and we have the renal artery here. Just in the way that we have understood the pathophysiology of myocardial infarction, where we have atherosclerosis, there is formation of a plaque which is comprised of lipids, collagen and platelets, right? So, this plaque can basically cause obstruction of the arteries, right? This is what we saw in the pathophysiology of MI. So, this happens in your coronary arteries. So, very similarly, atherosclerosis can affect the renal artery as well. So, when it affects the renal artery, what happens? It causes a kink similar to how it causes a kink in your coronary arteries, and this can in turn cause ischemia of the kidneys. So, the most common cause for renovascular hypertension is your atherosclerosis. Apart from that, atherosclerosis is common when? It is common in individuals who are more than 40 years of age and with risk factors like diabetes, hypertension, smoking, dyslipidemia. But in young individuals also, you can have renal artery stenosis where there is a narrowing of the renal artery. So, in young individuals, the most common cause in the world, is a disorder what we call as fibromuscular dysplasia. Now, fibromuscular dysplasia is an inherited disorder where you have a renal artery stenosis. This is the most common cause of renal artery stenosis in young individuals less than 40 years of age. Then other causes include large vessel vasculitis such as Takayasu arthritis. This is a large vessel vasculitis. Okay. Then you can also have polyarthritis nodosa. So, these are about the causes for renal artery stenosis. So, let us look at the two major representatives, or what we call as the two major causes for renal artery stenosis. So, one is atherosclerosis, other is your fibromuscular dysplasia. So, let us look at the differences. In atherosclerosis, in whom is it more common? Naturally, it is more common in the elderly. Fibromuscular dysplasia is a disease which basically affects the young individuals. Atherosclerosis is seen in both males and females, and it's associated with your traditional risk factors, smoking, dyslipidemia, diabetes, hypertension. Fibromuscular dysplasia is more common in females. Okay. Then, atherosclerosis is generally a bilateral process. FMD can affect unilateral kidney or it can affect both the kidneys. Okay. So, what happens in atherosclerosis we have learned? It's because of the formation of a plaque where there is narrowing. In fibromuscular dysplasia, what happens is that the muscularis layer is affected, right? So, there is a dysplastic artery. Because of this dysplastic artery, there are outpouchings which are created, and overall there is a increased resistance to the flow of blood through the renal vessels. Okay. So, which part of the renal artery is affected in atherosclerosis? It is usually the proximal part. It is usually the proximal part. But in FMD, which part is affected? It is usually the distal or mid portion which basically gets affected. Right? And what is the appearance that you see? What is the appearance that you see on the MRI? What you see is a string of beads appearance. What you see is a string of beads appearance. Right? So, when you do an MR angiogram or a CT angiogram, you see this string of beads appearance which is classically seen in fibromuscular dysplasia. So, what is the treatment? So, similar to the treatment of atherosclerosis in your coronaries, here also you can place a stent. Okay. Treatment for FMD is also the same. You do a stent. Okay. So, this is about the two main etiologies for your renal artery stenosis, which is your atherosclerosis and your fibromuscular dysplasia. Now, let us understand the pathophysiology and the clinical manifestations of renal artery stenosis. So, whenever there is a unilateral stenosis, so what happens when there is a unilateral stenosis? So, the stenosis is here. Now, because there is a decreased blood flow to this kidney, there is a decreased blood flow because of the stenosis, or there is a decreased perfusion to your kidney number 1, right? So, what happens? The body has to compensate. So, how is the compensation going to happen? There is going to be an increased blood flow to kidney number 2, right? So, there is an increased renal blood flow. Okay. So, because there is a decreased perfusion to one of the kidneys when there is a unilateral renal artery stenosis, there is an increased renal blood flow as a compensation. So, whenever there is an increased renal blood flow, what happens? We know that the GFR is going to increase. In the initial stages, the GFR will increase and there will be a pressure natriuresis. There will be a pressure natriuresis. What does that mean? Whenever there is an increased flow, then what happens is that there will be increased distal sodium delivery, right? So, what happens? You have to maintain the volume status. To maintain the volume status, the sodium is excreted out. So, there is a pressure natriuresis. Okay. Now, why is this pressure natriuresis important? This pressure natriuresis ensures that there is no untoward accumulation of your fluid in your lungs. Okay. So, there is no untoward volume expansion. You do not have edema. You do not have pulmonary edema as well. You do not have peripheral edema, you do not have pulmonary edema because of this pressure natriuresis which is seen or which is intact in your unilateral renal artery stenosis. Also, whenever there is a unilateral renal artery stenosis, there is stimulation of your renin-angiotensin-aldosterone system. We have learnt that whenever the kidney's perfusion is reduced, there will be stimulation of the renin-angiotensin-aldosterone system. So, this renin causes stimulation of angiotensin 1 to angiotensin 2 and aldosterone is also stimulated, which is responsible for the reabsorption of sodium and water from the kidney, right? So, what does this in essential help? Whenever there is renal artery stenosis, there is backward stimulation of RAAS because there is decreased perfusion and there is stimulation of your RAAS system. So, this renin in turn is going to cause an increased blood pressure, but they are not in volume overload because there is continued pressure natriuresis. Okay. So, the only clinical feature with which unilateral renal artery stenosis is going to present is with your uncontrolled blood pressure. Right? On an ultrasound, you see that there is an asymmetry in the kidney size. Right? So, you can have, whenever there is a decreased blood flow, you will have a shrunken kidney, maybe less than 8 centimeter. That is when we call it shrunken kidney, and the difference in size between the two kidneys is more than 1 centimeter. It is more than 1 centimeter. So, this is about the clinical features of renal artery stenosis unilateral. So, how do they present? They basically present as uncontrolled blood pressure requiring more than 3 classes of antihypertensive. In an elderly, especially if he has a prior history of MI, then it is a good chance that he has atherosclerosis of the kidneys as well. More than 3 classes of antihypertensives is how they present. And on ultrasound, when you do a screening ultrasound, you find asymmetric kidney size. Okay. So what are the ways in which you can diagnose this renal artery stenosis? Once you find that there is an asymmetry in the kidney size, you will have to do a renal Doppler. You do a renal Doppler examination. This shows us the flow across the renal artery. It gives us certain other indices like resistivity index and so on. And it shows us how much of narrowing is there. Followed by a renal artery Doppler, you do a CT angiogram or an MRI angiogram to see the status of the vessels and find out the etiology. Now, once you have found out the etiology, in a unilateral stenosis for blood pressure control, you give them ACE inhibitors. You might be remembering from your pharmacology classes, ACE inhibitors are contraindicated in what? They are contraindicated in bilateral renal artery stenosis. But in unilateral renal artery stenosis, the treatment is with ACE inhibitors. Okay, they help in reducing the blood pressure. If this is an atherosclerotic disease, which is unilateral, then you can do a stenting. Even if it is a fibromuscular dysplasia, you can do a stent. So, the moment you put a stent, then the narrowing will improve. It will help in improving the blood flow. Okay. So, this is about your unilateral renal artery stenosis. Now, let us look at the bilateral renal artery stenosis. So, when there is a bilateral issue, definitely there is a decreased perfusion, right? So, there is a decreased perfusion. Now, in both the kidneys, if there is a decreased perfusion, will you have pressure natriuresis? No, you will not have pressure natriuresis because there can be no compensation. In both the kidneys, the blood flow is low. The only thing that you will have is there is going to be increased renin and the blood pressure will be very, very high. So, what are the clinical features with which they present? They present here with flash pulmonary edema and frank renal failure. They present with flash pulmonary edema and frank renal failure, and they can present as a hypertensive emergency. Right? They present as a hypertensive emergency. Frank renal failure, hypertensive emergency with flash pulmonary edema because there is no pressure natriuresis and there is going to be accumulation of water in the lungs. Urine output is decreased, however, there is no peripheral edema. They come with a sudden onset of pulmonary edema. Most commonly, how do they present? They present after initiation of ACE inhibitors. So, now a patient has come with uncontrolled hypertension, you initiated him on ACE inhibitors and you have not found that there is a bilateral renal artery stenosis, then they can present to you with a flash pulmonary edema after the initiation of ACE inhibitors. Okay, right? So, how do you identify this? So, when you do a renal ultrasound, you will see that there will be bilateral shrunken kidneys, right? You cannot have asymmetry here because both the kidneys are affected. So, when you are thinking of this condition, when you are thinking of bilateral renal artery stenosis, you do a ultrasound and you do a renal Doppler, followed by which the investigation of choice will be an MR angiogram. The most common cause of bilateral renal artery stenosis in young individuals in India is your Takayasu's disease, which is your pulseless disease, and this vasculitis affects both the renal arteries and they present in a similar way with hypertensive emergency, flash pulmonary edema, and you can find evidence of vasculitis in your MR angiogram. So, how do you treat this kind of a patient? So, you will have to give them nitroglycerin or hydralazine, you reduce the afterload and you bring down the blood pressure. Okay, you give them diuretics to decrease the pulmonary edema. And the final or definitive treatment will be to put a stent on both sides, and ACE inhibitors are contraindicated in bilateral renal artery stenosis. Okay, so I hope this is clear. So, what are the conditions which cause unilateral? What are the conditions which cause bilateral? And how both of them present differently. Okay, fine. Now, let us move on to the next group of disorders, which is your thrombotic microangiopathy. So, thrombotic microangiopathy can be caused due to different etiologies. So, this is the list of etiologies. It includes what we call as the hemolytic uremic syndrome. Then we have your antiphospholipid antibody syndrome, preeclampsia, HELP syndrome, scleroderma renal crisis. Any of these disorders can affect the small vessels of the kidney, right? It can affect the segmental arteries, it can affect the arterioles, and it can cause your thrombotic microangiopathy. Okay. So what exactly happens in this? Why is it called thrombotic microangiopathy? Is because any of these conditions can predispose to microthrombi. It can predispose to microthrombi which go and attach themselves to the vessels and cause blockage of these small vessels and in turn cause damage to the kidney. Okay, that's why it's called a thrombotic microangiopathy. So let us look at your hemolytic uremic syndrome. So as the name suggests, what are the clinical features for your hemolytic uremic syndrome? So the triad of clinical features for your HUS is your hemolytic anemia with renal failure and thrombocytopenia. So hemolytic anemia with renal failure and thrombocytopenia. So hemolytic anemia, how will it present? It's basically presents with a HB drop, right? It will present with a hemoglobin drop. Apart from that, you will have indirect hyperbilirubinemia, the TBDB of which total bilirubin will be elevated and the indirect bilirubin or the unconjugated bilirubin will be increased. Then apart from that, what will you find? You will have increased LDH levels. You can have increased LDH and decreased haptoglobin levels. Right, so we have hemoglobin drop, indirect hyperbilirubinemia, increased LDH, decreased haptoglobin. So this is what are the laboratory features of hemolytic anemia. Next, you can have renal failure, which is characterized by increased creatinine, decreased urine output, increased blood urea. Okay, and you can have thrombocytopenia. The most characteristic peripheral smear manifestation is the presence of what we call as these bite cells, which we call as schistocytes. Okay, so what happens is that these cells get broken down and they appear as schistocytes in the peripheral smear. So these are the most important clinical features with which your hemolytic uremic syndrome presents. So hemolytic uremic syndrome can occur in childhood or in adulthood. Your typical HUS basically presents in childhood, right? So how does it present? It basically presents with an episode of bloody diarrhea, followed by hemolytic anemia, renal failure and thrombocytopenia. Okay. So what happens here? This is a type of thrombotic microangiopathy. With this clinical features, what happens is that there is damage to your small vessels of the kidney resulting in renal failure. So the most common organism is your enterohemorrhagic E. coli. EHEC is your enterohemorrhagic E. coli O157H7 strain. Apart from that, so the toxin which is produced by your EHEC is your Shiga-like toxin. Apart from that, you have your Shigella dysenteriae and your streptococci. The streptococci associated with what? It is your neuraminidase toxin. Right? So all of these infections, so most importantly in children, this is a post-infectious process. The most common organism is your enterohemorrhagic E. coli, then Shigella, streptococci. All of these can cause your HUS. So in all of this, there is an episode of bloody diarrhea followed by your triad of HUS features. It usually takes about 1 week for your clinical symptoms to appear. Okay. And what are the laboratory features? We have already seen. So what is the treatment for childhood onset HUS? The treatment for childhood onset HUS is that it is a conservative treatment. Right? You have to just observe the child. You have to give them blood transfusions if it is required, if the anemia is too low. Otherwise, you have to just observe, give them enough IV fluids and the prognosis is good. Okay. So recovery is the rule in your childhood onset hemolytic uremic syndrome. In your adult onset HUS, this is also called as atypical HUS. So this is often not triggered by infections. So the most common cause is a genetic cause because of complement factor H or B mutation, right? So this complement factor H and B are basically involved or associated with your C3 convertase. So it's basically involved in the breakdown of C3. So whenever there is a mutation in that, there is unregulated complement activation which causes damage to the small vessels or the vasculature of the kidney and causes renal failure. Okay. Apart from that, drugs such as mitomycin, cisplatin, tacrolimus, cyclosporin, clopidogrel, all of them are associated with your TMA, thrombotic microangiopathy. Then HIV and pregnancy. So, in adult onset HUS, the prognosis is very poor. The prognosis is very poor, right? Many of the times they can also become dialysis dependent. So, the treatment is by plasma exchange and another monoclonal antibody which you have seen in the treatment of PNH, right? Eculizumab. So, this is your CD55, CD59 antibody which is your eculizumab, right? So, this is about your adult or your atypical HUS. So, till now what have we learned? We have learnt about TMA. What are the causes for TMA? We have learnt about HUS, childhood onset and atypical HUS. Okay. So, this brings us to the end of our discussion on the vascular disorders of the kidney. So, to summarize the vascular disorders, we have learnt about large vessel and small vessel disorders. Large vessel disorders are your renal artery stenosis, small vessels. The highlight or the most important one is your HUS, which we have learnt in detail. Thank you.